In a collapsed society, the medical supply chain is gone. There are no trauma bays, no multidisciplinary surgical teams, and the golden hour for casualty evacuation simply does not exist. When a firefight ends and a survivor takes a ballistic impact, you are the absolute final echelon of care. You must execute raw damage control surgery directly in the dirt. To keep a casualty alive for days or weeks, we have to master 3 critical phases: stopping lethal arterial bleeds, physically decompressing a collapsing lung, and utilizing biological assets to salvage necrotic limbs. This drawing illustrates the exact trauma loadout you need to execute these phases. You must have windlass tourniquets, vented chest seals, 14-gauge decompression needles, thermal blankets, a surgical scalpel, and, eventually, medicinal maggots. In a zero evacuation scenario, absolute mastery of these gritty, step-by-step interventions is the only barrier keeping a wounded survivor from bleeding out in the wasteland. Step 1 begins while bullets are still flying. During care under fire, your absolute priority is suppressing enemy forces. You cannot perform complex medical diagnostics in a volatile environment. Your only permitted intervention is deploying a hasty tourniquet. This schematic shows a severed femoral artery pumping blood into the surrounding tissue. You must apply the tourniquet directly over the casualty's clothing, placing it as high and tight on the affected limb as physically possible. Then turn the windlass relentlessly until the distal pulse completely vanishes and the bleeding halts. Once you maneuver behind hard cover, the focus shifts to tactical field care and the mechanics of human respiration. The human lung operates within a vacuum. A ballistic path through the chest wall breaks that vacuum, drawing ambient air into the chest cavity with every breath and collapsing the lung. You must seal any open torso wound instantly with a vented chest seal. The one-way venting channels allow the trapped air to escape upon exhalation, while firmly preventing ambient air from entering during inhalation. If you observe progressive respiratory distress, hypoxia, or profound hypotension, the casualty is developing a tension pneumothorax. Trapped air is building immense pressure inside the chest cavity, violently displacing the mediastinum and shutting off venous blood flow back to the heart. To vent that pressurized air, you must perform a needle thoracostomy. This animated blueprint shows the exact target site, the 5th intercostal space at the anterior axillary line. You insert a 14-gauge, 3.25-inch needle perfectly perpendicular to the chest, riding exactly over the top of the lower rib to intentionally avoid the sensitive neurovascular bundle. Do not use the traditional 2nd intercostal space at the mid-clavicular line. Cadaveric studies show this upper chest approach has a catastrophic 82% misplacement rate. Operators frequently place the needle dangerously medial to the nipple line, directly threatening the heart and major blood vessels. Securing these basic mechanics, arresting massive hemorrhage, and restoring internal air pressure is the absolute minimum requirement. Without these stabilized, the casualty cannot survive the grueling marathon of long-term care that follows. With acute trauma managed, you have to aggressively guard against the lethal triad, a deadly self-feeding loop of hypothermia, acidosis, and coagulopathy. If a casualty has lost massive blood volume, do not infuse them with standard clear fluids like normal saline. Saline provides zero oxygen transport, dilutes the body's remaining clotting factors, lowers core body temperature, and will ultimately accelerate exsanguination. Instead, combat hemorrhagic shock using fresh whole blood or lyophilized plasma, known as FLIPE, which replaces crucial coagulation factors. You must also intravenously administer tranexamic acid, or TXA, within 3 hours of the initial injury, to prevent the body from prematurely breaking down the life-saving clots that have already formed. Fluid replacement must be paired with immediate environmental intervention. Strip away all wet clothing and tightly wrap the casualty in a hypothermia prevention and management kit, or any available improvised thermal barriers. If you allow a trauma patient's core body temperature to drop out there in the dirt, the enzymatic processes required for blood clotting will simply cease to function.
Once that happens, no amount of advanced pharmaceuticals or surgical skill will save them. Eventually, the shooting stops. The acute ballistic trauma is stabilized, but the true test of wasteland survival begins. Welcome to prolonged field care, where your casualty becomes a ticking biological time bomb of tissue necrosis and systemic infection. A gunshot wound creates a massive cavity of shattered tissue and environmental debris. You must wash this cavity out under high pressure. The optimal fluid is Dakin solution, a diluted bleach formulation. If that is unavailable, use clean tap water or violently boil non-potable water for a minimum of 3 minutes. Let it cool and force it into the wound. Irrigation alone will not stop a catastrophic infection. You have to physically excise all dead and dying tissue from the body using a scalpel. This process, called debridement, is excruciating. You will need potent dissociative agents like intravenous caidine or direct injections of lidocaine into the wound margins to manage the casualty's pain and physical shock. If you use lidocaine mixed with epinephrine to control surgical bleeding, never inject it into the distal extremities, the fingers, toes, nose, or ears. The intense localized vasoconstriction will cause complete ischemia, leading directly to gangrene. This diagnostic table illustrates how to separate living flesh from dead flesh in a dimly lit, austere setting. You must rely strictly on the 4 C's of muscle viability: color, consistency, contractility, and circulation. Healthy muscle is vibrant, firm, twitches when pinched, and bleeds actively when nicked. Necrotic tissue is mushy, gray, and completely unresponsive. You must meticulously cut away all tissue that fails this test. But what happens when pharmaceutical supplies are completely exhausted, surgical instruments are dull, and severe necrosis firmly sets in? You turn to ancient biological warfare against infection: maggot debridement therapy. This therapy relies on the sterile larvae of the green bottle blowfly, Lucilia serracata. As these maggots crawl through the wound bed, they secrete a potent cocktail of digestive enzymes that specifically target and chemically liquefy dead necrotic tissue, while leaving healthy living tissue completely untouched. They literally eat the necrosis away. Beyond physical removal, their excretions contain sodium bicarbonate, which actively raises the pH of the wound bed to inhibit pathogenic bacterial growth. Their secretions even introduce growth factors that mimic human hormones, actively promoting the rapid genesis of new blood vessels. These schematics show the 2 application strategies. On the left is the confinement dressing, which tapes a breathable net over the wound, allowing the maggots to roam free for maximum speed of debridement. On the right is the containment dressing. Here, the maggots are sealed within a highly porous polyester bag placed directly into the wound, preventing escape and significantly reducing psychological distress for the casualty. When sterile operating rooms are a thing of the past, embracing brutal physical decontamination and ancient biological allies is the only proven method to arrest systemic sepsis and save a limb. Even with aggressive debridement, the risk of systemic infection from a gunshot wound remains critically high. You must administer broad-spectrum oral or intravenous antibiotics for 7 to 10 days to combat sepsis. This brings us to the most critical ironclad rule of austere field surgery. A gunshot wound must never be primarily sutured closed in the field. This scorched page emphasizes the warning. The kinetic energy of a bullet permanently destroys tissue and embeds environmental debris deep inside the cavity. Closing a contaminated wound is a guaranteed method to trap anaerobic bacteria inside the body, rapidly inducing a lethal abscess. You must leave the wound open to drain. Temporize it with simple, breathable dressings and allow it to heal slowly through delayed closure or secondary intention. Surviving the initial ballistic impact is merely the prologue. Without medical evacuation helicopters or automated monitors, the burden of life and death falls entirely on your mastery of raw human mechanics. Knowledge and ruthless pragmatism are your only remaining tools. In the Wasteland, the operator is the final echelon of care.